So I'm going to build somewhat on the talk you heard yesterday from Marcia, which was wonderful. The work that they have done on reducing the incidence of incontinence-associated dermatitis. And what I'm going to share is just what we currently know about the pathology, the risk factors, and prevention protocols and management strategies. And I think I'm primarily going to reinforce what you already know, maybe fill in a few gaps. So a lot of you are aware that incontinence-associated dermatitis is a relatively new concept, that for a long time, moisture-related skin damage, incontinence-associated dermatitis, was really considered just within the framework of pressure ulcer prevention and pressure ulcer development, so one of the risk factors for pressure ulcer development. Back in 2007, a consensus conference was held to discuss the issue of skin breakdown that was really caused by exposure to stool and urine. And that's when the term IAD, incontinence-associated dermatitis, was introduced. Because there was no other term being used that accurately captured what we were seeing in clinical practice. Diaper dermatitis, that was a pediatric term. Ammonia dermatitis. Reflected damage related to urine exposure, but what about damage related to stool exposure? Perineal dermatitis didn't capture it because it wasn't just the perineum involved. So incontinence-associated dermatitis addressed the underlying etiology and the resulting clinical phenomenon. That was helpful in that within the realm of wound care, it helped to start separating out wounds caused by pressure and wounds caused more by moisture, and made people much more aware of the whole concept that moisture can indeed cause significant problems with skin integrity. We also introduced the concept of moisture-associated skin damage, and we recognized that IAD is one type of moisture-associated skin damage. Following that change in terminology and a concerted effort on the part of many people in continence care and in wound care to start using correct terminology, we've seen an increase in the number of studies related to pathology, prevention, and management, which was one of the goals. So you all know very well what IAD is. You know that it's inflammation of the skin caused by chronic or repeated exposure to urine or stool or both. Primarily stool, we're going to come back to that. At this time, there are 4 recognized types of moisture-associated skin damage. IAD is one, intertriginous dermatitis is another, and actually as continence experts, you may see patients with ITD as well as IAD, and we're going to talk about that briefly. Peristomal MASD and Periwound MASD, the other 2 types. So differentiating between IAD and ITD, IAD, by definition, is limited to conditions where stool and urine exposure are the etiologic factors. ITD references damage due to trapped moisture. Many times trapped moisture, which we see a lot in our obese patients, we see a lot in our diaphoretic patients, but we can also see that in our incontinent patients. So sometimes it's simply trapped perspiration. Sometimes it's a combination of trapped perspiration and trapped urine. So how prevalent is IAD? Well, that's one of the most important messages, is that now that we're actually able to track prevalence of IAD separate from pressure ulcer prevalence, we recognize this is a very common issue. 10 to 35% of community-dwelling adults with urinary incontinence have IAD. I know you see this when people come into your clinics and they come in with skin damage as well as all of these other complaints. Among community-dwelling adults with fecal incontinence, 50% have IAD. In long-term care, up to 65% of patients with incontinence, and in ICU, 83%. And I know in our setting, our ICU patients seem to be our most vulnerable patients, and they're the patients who have C. diff. The other big factor in terms of importance is that IAD is painful. It's usually preventable, it's acutely painful. And especially in our patients who have IAD as a result of fecal incontinence, they can have very rapid progression of very severe skin breakdown that is so painful for the patient, and it gets to be painful for the nurse to even try to provide care. The other thing is that when you have skin that is damaged by exposure to urine and or stool, you get skin that is overhydrated, you get skin that is very vulnerable. Wet skin drags against linen, against underpads, and that drag factor causes friction damage and skin loss. Wet skin is unhealthy and vulnerable. Dry skin glides. Wet skin does not support weight, does not distribute weight effectively. So wet skin is also much more vulnerable to pressure damage, and to shear damage. So looking at the pathology, I think you're already probably very familiar with this, but we always start with the effects of overhydration, that wet skin. So we know that when you have overhydrated skin, if you look down at the cellular level, those skin cells are overhydrated and the cell membrane is stretched. And a cell membrane that is stretched is very vulnerable, so that very minor mechanical trauma will cause disruption of the cell membrane. And when that happens to multiple cells at the same time, the end result is skin loss. We've already talked about increased drag against sheets, which also increases the risk of friction damage. So we've got the negative impact of overhydration. Then within the world of IAD, nursing interventions to manage the problem actually contribute to the problem. We have to clean them up after each incontinent episode, but repetitive cleansing can cause loss of skin cells and loss of the skin oils that help to maintain that intact skin barrier. Part of it goes back to technique, and we'll come back to that, but if you think, what if you showered 4, 5, 6, 8 times a day? Every time you shower, you're scrubbing off some skin cells and you're drying off. And you could literally cause damage by repetitive excessive showering. So you think about the perineum, you think about skin that's already very vulnerable because of exposure to stool and urine, and then you think about repetitive cleansing. And every time we clean them, we run the risk of taking off layers of skin cells. If the person cleansing them is aggressive, and many times our frontline caregivers are very focused on getting somebody clean and not so focused on maintaining skin health, and they're scrubbing them up. Do you see patients getting scrubbed up? And I was a nursing assistant before I was a nurse, and I was a scrubber. My patients were clean. They might be missing a few layers, but what they had left, very clean. The other thing that happens every time we clean them up is we tend to strip the oils from the skin. Now, we know that the structure of intact skin is you have your skin cells, and then in between the skin cells, you have skin oils. And those skin oils serve very much as the mortar in a brick wall. So you think about a brick wall, you've got your bricks, you've got your mortar. How important is the mortar? Pretty important. If I chink out all the mortar, what good is my brick wall? It's no good. It doesn't have integrity. It will fall apart, and it allows everything to pass through. So every time I clean them up, I'm potentially adding to the problem by stripping away skin cells and stripping away skin oils. Once I create chinks in the barrier, then it's a straight shot for the irritants in urine and stool and the bacteria or fungal organisms to go straight into the underlying layers of the skin and trigger an acute inflammatory process. In addition, we get changes in pH, so overhydrated skin is much more alkaline, and we know that alkalinity reduces resistance to bacterial penetration, so that change in pH is negative, and we've already talked about the impact of friction. So there's a concept out there when you look at what happens with IAD or any kind of moisture-associated skin damage, it's moisture plus question mark. So moisture is seen as the setup guy. Moisture makes the skin more vulnerable. Overhydration does not usually in and of itself cause skin loss, but it makes the skin much more vulnerable. And then the factors that actually cause skin loss have an open door because they have a very vulnerable host. So mechanical trauma from cleansing from friction, penetration by irritants and enzymes, and penetration by bacteria or by fungal organisms. Risk factors for IAD, you could write this list as well as I can. This comes from the literature, but we all know this. So the first is, how much of a threat do I have in terms of how bad is the incontinence? And is the incontinence limited to urine or to solid stool, or does it involve liquid stool? So the current evidence says that exposure to liquid stool is the greatest risk factor. It's top of the pyramid. Repetitive exposure to a combination of urine and solid stool, also a significant threat. Urine alone, when you look at incontinence, the least threat. What about the skin at baseline? If the skin is already very vulnerable because this individual is elderly and they have thinner skin because they're malnourished, and they have thinner skin because they're on steroids, because they have multiple comorbidities, then it's going to take fewer hours, fewer incontinent episodes, fewer cleansing procedures to result in skin breakdown. What impact would functional and cognitive function have? Well, you already know that. You deal with this every day in incontinence care. If I'm cognitively intact and I have good mobility, I'm going to self-toilet, and it significantly reduces my risk for incontinence and for IAD. If I'm functionally impaired but cognitively intact, I'm going to know when I have an incontinent episode, and I'm probably going to get somebody in there pretty quickly. Also, if you start getting too aggressive in cleaning me up, I'll let you know. But what if I'm cognitively impaired and functionally impaired? Then I'm totally dependent on the staff understanding what's going on and understanding how to protect my skin. Fever, diaphoresis, simply because they make the skin more vulnerable at baseline. And then the last two I want us to focus on because these are very much under our control. You heard a lot about inappropriate use of absorptive products and the negative impacts of occlusion yesterday. We'll talk briefly about that. And then again, how are we going about cleaning up these very vulnerable patients? Are we being aggressive? Are we being gentle? What kind of products are we using? So now we're going to spend the rest of the time taking what we know about pathology and translating it into a simple and effective prevention protocol. Again, you heard a lot of this yesterday. And then into a management program. So of course, we have two major goals. One is, let's start from the skin side, and let's do everything we can to keep the skin as healthy as possible. And healthy skin, by definition, is dry, acidic, and supple. Now, when I say dry, I don't mean dry and cracking and itchy. I mean dry as in not wet. Acidity, hostile to bacterial and fungal overgrowth. Supple means that I have moisturizers applied routinely to fill the gaps between the cells and to keep the skin mobile. If I'm able to do that, if I can keep the skin dry, supple, and acidic, it means I have an intact barrier that's going to be very resistant. It's going to be hard for irritants to get through, hard for enzymes to get through, hard for organisms to get through. To translate that, how do I keep the skin healthy? I prevent overhydration, I avoid aggressive cleansing, and I routinely replace moisturizers, the lipids in the skin, the oils that fill the gaps. The second thing I want to do is I want to minimize contact with the threat. The threat is urine and stool, and especially stool. So I want to minimize contact between the skin and the urine, between the skin and the stool. Maceration, remember overhydration is the setup, guys. So if I can prevent overhydration and keep the skin healthy, I significantly reduce this individual's risk. And this was covered beautifully yesterday, so I'll summarize. We should be using absorptive products only when essential. And sometimes they are essential. But first I should see, can I toilet this patient? What did we hear yesterday? Toilet, toilet, toilet. Exactly right. Secondly, could I use a containment product instead of an absorptive product? Could I use a condom catheter? Could I use a fecal containment pouch? If I have to use absorptive products, I need to use them wisely. There's a wide variety of products on the market, you know that. Some of them are very poor quality, and they form wads and clumps underneath the patient. And others are very good quality. They're polymer-based, and they wick urine away. So we have products that are based on excellent research into diaper dermatitis and that provide the same benefits to our patients that the newly formulated diapers provide in the pediatric arena. And we know that there's a huge reduction in diaper dermatitis based on marked improvement in products available, both diapers and cleansing products. We can take that research and apply it to our vulnerable patients. So, first of all, can I toilet? Secondly, can I contain and divert? If I have to use absorptive products, I'm going to fight for quality products that have polymers that wick. I'm going to do my best to avoid occlusion, to keep products open and flat under the patient. So using absorptive underpads instead of adult diapers or briefs. And not closing them up around the patient, because as soon as I close up a product that has a plastic cover, what am I doing? I'm elevating the temperature and contributing to maceration. I make the skin hot and sweaty. And now the skin's vulnerable. But our frontline caregivers don't know this until we raise their consciousness. And so that's what your team did a beautiful job of doing, raising consciousness, adding a new perspective, because what are people typically doing? They're protecting the bed. They're keeping the sheets dry, right? And so we want them to focus on the skin instead of the sheets. We also want to use moisture barriers appropriately, and we want to provide appropriate cleansing. So appropriate cleansing, what I would like for people to think when they're doing continence care, I would like for them to think of infant care. I very rarely see anybody scrubbing infant skin or picking at infant skin, but I see people scrubbing and picking at fragile elder skin every single day. So I've thought about hanging up no picking zone, no scrubbing, no picking zone signs to, get the message, don't scrub, don't pick. Don't use standard hospital issue washcloths. Use very soft cloths. Look at baby wipes. Are they coarse? Do they look like sandpaper? No, they're very soft and gentle, and that's what we should be using. So we should be using disposable washcloths that are very soft, or we should be using impregnated wipes. Every time we do continence care, we should be replacing those skin oils. So we should be gently removing stool and urine and replacing the lost skin lipids to keep the skin healthy. Good moisturizers are going to be all of your oil-based products, your dimethicone products, your petrolatum, and we'll come back to that. You heard a lot yesterday about how important it is to minimize contact with stool and urine, that toileting should always be our first choice. Can this patient be toileted? But if I can't toilet them before I automatically put them in an absorptive product, I should think, what else is available to me? Can I use a condom catheter on this male patient with urinary incontinence? We know that fecal incontinence is the greatest threat, and especially incontinence of liquid stool. In ICU, very high incidence of C. diff and other forms of antibiotic-associated diarrhea, extremely damaging to the skin. I don't care how high level my absorptive products are. If I'm forced to use absorptive products on a patient with C. diff, I'm probably going to have bad outcomes. So I want to think, can I either pouch them or can I use an internal bowel management system? One of the challenges in most hospitals is that even though the fecal pouches are readily available, people don't think about them. And so by the time they start to think about doing that, you either have damaged skin and the pouch doesn't stick, or people have used so much grease on the skin that they won't stick. So again, consciousness raising, what are your options? Getting them to think about pouching earlier. But probably the most effective strategy for your patient with liquid incontinent stool is your internal bowel management systems. Making sure that they're available, making sure staff know when to use them, making sure staff know how to use them, and know how important they are. Okay, so those are the things we're going to do to try to keep the skin healthy and minimize contact. We're going to look at how we provide routine skincare. So we're going to do gentle cleansing. We're going to routinely replace lipids. We're going to toilet when we can. We're going to use containment products when we can. If we have to use absorptive products, we're going to routinely use a moisture barrier to try to minimize contact between the skin and the urine, between the skin and the stool. Now, if we looked at the perfect moisture barrier, and your moisture barriers are these creams and ointments that we apply all the time, we would like the barrier to replace lost skin lipids so that they keep the skin healthy. We want them to effectively protect the skin against urine and stool. So if you have an umbrella, do you want it to be waterproof? We don't carry paper umbrellas, right? For a reason. So I need an effective moisture barrier. But I also want, if at all possible, to get one that I can apply without causing trauma and I can remove without causing trauma. So what's currently out there? Well, we have Petrolatum-based products, dimethicone-based products, zinc oxide-based products, combination products, and liquid barrier films. What's best? There is no one best product. You want to be aware of, well, what are the features of this type of moisture barrier, and how does that translate into when I would use it? So let's look at petrolatum-based products. They are effective moisturizers, so they help keep the skin healthy. They give good protection against urine and against solid stool. They're not very effective against liquid stool. Easy to apply, easy to remove. You can see through them so people can see the skin and monitor the skin and they don't feel the urge to scrape it all off. But if people don't know how to use them correctly, a lot of caregivers think, well, a thicker layer is better than a thin layer, and that is not true of petrolatum. Studies have shown that if you apply a thick layer, that it will transfer to the underpad or the brief, and it will waterproof the underpad, waterproof the brief, but it won't be protecting the skin. So a thin layer is better than a thick layer. And petrolatum is not very good for damaged skin. It will slide right off. You've seen that happen probably many times in clinical practice. Sometimes you can add a powder and that will allow it to stick. Sometimes even then it won't stick. What about dimethicone? It's a great moisturizer, so it helps keep the skin healthy. Pretty effective against urine and solid stool, not at all effective against liquid stool. One advantage, it's non-occlusive, non-greasy, so it feels good to the patient, doesn't transfer. You can see through it, it's atraumatic, but it's not going to work if you need to treat damaged skin. It's pretty much prevention only. What about zinc oxide? I bet everybody has a zinc oxide-based product in their formulary. Not a moisturizer. So zinc oxide in general, not as good for prevention. But why do we go to zinc oxide? When do we go to zinc oxide? We go to zinc oxide because it's the one product on the market that's most effective against liquid stool. And it's more effective with damaged skin. But again, you have to combine it with an absorptive powder or it slides right off and doesn't do what you need it to do. What's the big disadvantage of zinc oxide? It's the flip side of why it works. Why is it good for liquid stool and damaged skin? Because it's thick and it's hard to get off and it's hard to penetrate, so it's hard for stool to get through it. What's the downside of zinc oxide? It's thick, it's sticky, it's hard to get off. And sometimes if people don't know what they're doing, they cause more damage with inappropriate use of zinc oxide. I've seen people scraping it off with tongue blades, Hopefully you haven't seen anything that bad. So we have to teach people. You can remove this without causing trauma. Use your impregnated wipes or your perineal skin cleansers. Don't try to remove it with water only. It won't work. And be careful if you have trouble getting the zinc oxide to adhere because the skin's wet. Then if you have access to zinc oxide impregnated gauze, you could fan fold gauze strips and just lay them over the at-risk area. Or you could use a product that has a combination of zinc oxide and petrolatum. The petrolatum makes it easier to apply and remove, and the zinc oxide bumps up the level of protection. If you have access to ostomy powder, like pectin-based powder, you can sprinkle that ostomy powder onto the damaged skin before you apply the zinc oxide. If you also have access to your alcohol-free liquid barrier films, you can sprinkle on the ostomy powder, spray the liquid barrier film, let it dry so you've created a crusty, dry coat as your base coat, and then apply your zinc oxide. That's much more effective when you already have damaged skin. So I got ahead of myself. I already talked about combination products, why the combination of petrolatum and zinc oxide can be helpful. And then finally, your liquid barrier film. So these are the spray products that are frequently used in ostomy care and wound care. They come in sprays, they come in wipes. I'll throw out several different names. So Skin Prep, Sure Prep, Cavalon by 3M, probably every company that does wound, ostomy, and continence care has one of these. So there have actually been some studies done looking at these products for skin protection, and they are very effective against urine and solid stool. Again, less protection against liquid stool. Less frequent applications required, so whereas we reapply ointments after every incontinent episode, with your liquid barrier films, you can apply them once a day, and in one study, only 3 times a week. You do have the option, if the skin's damaged, put down your ostomy powder first, or your antifungal powder if they also have a fungal rash, and then spray or blot. And they can be used as a base coat followed by a moisture barrier ointment. So it's just another trick in your arsenal. So if I summarize prevention, it's just what you heard yesterday. Toilet them if possible, use containment when feasible, limit absorptive products to situations when there's no other option. When you're using absorptive products, avoid occlusions, so try not to close them up around the patient. Unless the patient's out of bed going off the unit, there's a specific reason to do so, and change promptly. What about skincare? 3 critical elements. These are all based on clinical consensus. That's what CC means. So gentle cleansing with a pH balanced cleanser, no regular soap. Routine use of a moisturizer to fill the gaps between the skin cells and keep the skin healthy. Use of a moisture barrier to protect the skin against the negative effects of stool and urine. How often should we apply it? Well, most of the time we write the order for daily and PRN, or Q12 hours and PRN. There was one study done in an ICU, and they wrote the orders for Q6 hours in PRN, and they compared that protocol to the Q12 in PRN and found a significant reduction in IAD when they used the Q6 in PRN protocol. So frequency may really matter. I'm going to use our last few minutes to talk about management protocols. Now, hopefully, we do a great job with prevention, and we have very few patients who require management. If they do require management, we're going to look at it in terms of 3 categories: mild irritant dermatitis, severe irritant dermatitis, and yeast dermatitis. Mild irritant dermatitis means you can see that there's inflammation, you've got redness, you've got tenderness, when the patient starts to pull away when you're cleaning them up, and you can see that the skin's inflamed. But at this point, you have no skin loss. So your goal is interrupt the cycle, prevent any progression, don't let them move into actual skin loss and severe dermatitis. If a prevention protocol is not in effect, you're going to initiate a prevention protocol. But what if I'm already doing prevention and they went from skin that looked normal to skin that looks inflamed? Then my current prevention protocol is not effective. I have to reevaluate. I have to ramp it up. If I'm using a lower level moisture barrier like dimethicone or petrolatum, maybe I need to step it up and use petrolatum and zinc so I give a higher level of protection. It's our general rule of thumb in nursing and healthcare. If what I'm doing isn't working, I go to the next level. But most of the time when you're doing management, you're dealing with severe IAD or yeast dermatitis. Severe IAD, this is the patient who has intense erythema and tenderness. They have a lot of pain. They may have blister formation. They either have patchy areas of skin loss or they may have extensive areas of skin loss. And obviously, I want to promote healing. And I've got to eliminate contact between the damaged skin and the stool and urine. So again, I re-look at what am I doing? Am I using absorptive products? Can I eliminate them? Can I go to a containment product instead? If I'm using an absorptive product, is it a good quality absorptive product? And does everyone know to leave that product open and not close it up around the patient so we don't get the negative effects of occlusion? How are we going about cleansing? Does everyone know how critical it is to do gentle cleansing? And I've got to use high-level moisture barrier protection. So I've got to use a zinc oxide product. And if they have significant skin loss, I may very well need to go to a layered approach where I put down my ostomy powder and my alcohol-free barrier film as my base coat, and then I put my moisture barrier on top. If you do that, you reapply the powder and the alcohol-free spray daily. You reapply the moisture barrier like your zinc oxide after each incontinent episode. Are there alternatives in the literature? Well, there were some studies done on a product known as BCT, which was balsam of Peru, castor oil, and trypsin. Now trypsin's been pulled out of all of those products, and so we have balsam of Peru and castor oil. And no studies done on that particular formulation. So if you're using that and you're getting good results, I would say continue on. It certainly does provide you with a moisture barrier. If the patient's not responding, again, you bump it up. Candidiasis, you know as well as I do. You know how to recognize it at 100 yards. You know that the patient's going to complain of both itching and tenderness. And you know that just a moisture barrier is not enough, that you have to use an antifungal. So you go back to everything we know about reducing moisture at the level of the skin. So no occlusion, frequent check and change, using a pH balance cleanser, using a moisture barrier that has an antifungal agent like your azole agents. Azole agents actually more effective, so products like miconazole actually more effective than your nystatin-based products because they have a broader spectrum of activity and they're less expensive. Most of the time, the simplest way to provide protection for a patient who has candidiasis as well as active treatment is simply a moisture barrier with an antifungal. You could alternatively take an antifungal powder, sprinkle it over the area, spray it with your alcohol-free liquid barrier film, and then coat with a moisture barrier. Or you could sprinkle the powder and then coat with your moisture barrier, but that's more steps. And we're going to talk about how more steps translate into reduced adherence to the protocol. So if you can, instead of using a plain moisture barrier, use an antifungal moisture barrier, then it simplifies and meets all your treatment goals. So here's the thing. I haven't told you anything you didn't already know. And this is not rocket science, and it's not a bunch of new information. But it's frequently hard to sell. What did you hear yesterday? It's all about selling the program, getting everybody on board, changing long-held perceptions, right? So we want people to think IAD is painful and it's preventable. As the leaders of the program, Our key functions are, first of all, to establish very simple, easy to follow protocols, to limit the number of products available so we limit confusion. If I can take a clean them up, moisturize, and protect protocol from 3 steps to 2, I'm going to get better adherence. If I can take it to 1, I'm almost guaranteed that the patient's going to get what they need. So when you think about setting up your formularies, setting up your protocols, you should have at maximum 4 products: a pH balance cleanser or impregnated wipes, either a liquid barrier film or a moisturizer moisture barrier combination. So a lot of your products will have like dimethicone and petrolatum. So that's a combination moisturizer moisture barrier. But if you have impregnated wipes, you can use 1 product instead of 2. If I have impregnated wipes, then they come with surfactants to lift stool and urine away from the skin, a gentle soft cloth that will not add trauma, and dimethicone or a comparable moisturizer. So in simply cleaning the patient up, you have provided cleansing, moisturizing, and a baseline moisture barrier. So impregnated wipes have a lot to offer. They replace 2 products. But if you can't get them, then you want your pH balance cleanser and a moisturizer moisture barrier combination for routine care. This is what we do for prevention. We use this cleanser, these disposable washcloths, and this moisturizer moisture barrier combination across the board. If the patient has open areas, if they have severe dermatitis, then we're going to use either our impregnated cleansing wipes to clean them up or our pH balance cleanser and soft cloth to clean them up, and then we're going to use our zinc oxide or combination product for management of those open wounds, right? And then if I have a patient with candidiasis, I'm either going to use my impregnated wipes or my pH balance cleanser and soft cloths for cleansing, and I'm going to use an antifungal moisture barrier. So theoretically, you could have 3 products: impregnated wipes, a zinc oxide-based ointment, and an antifungal moisture barrier. And then you would teach, here's what we do for routine care. Use the wipes, period. Here's what we do for damaged skin. Use the wipes and then coat them with zinc oxide. If it doesn't stick, sprinkle on ostomy powder first and then your moisture barrier, your zinc oxide. Here's what we do for yeast. Clean with the wipes and use this moisture barrier with an antifungal. See how you can really drill it down. Because I was doing a presentation for one group and I asked them, show me what you have in your formulary. Oh my God, they had a ton of stuff. They had multiple moisture barriers, they had a couple of antifungals, they had plain zinc oxide, combination zinc oxide. So I said to the staff, how do you know which one to use when? They're like, we haven't a clue. We just reach out, whatever we grab, that's what goes on their butt. Okay, well that's not very good evidence-based practice. So we want to streamline our protocols, streamline our inventory. I think I've got 2 minutes. So I did want to briefly mention IAD versus ITD, because I know you're going to see, if you're in acute care and even if you're in a clinic, you're going to sometimes see ITD as well as IAD. So ITD, intertriginous dermatitis, by definition, skin damage caused by trapped moisture and frictional forces between 2 opposing skin folds. So this is what you see underneath the pannus, in the groin folds, in the gluteal cleft. How many of you have seen this kind of breakdown, okay? And when you look at the basic mechanism of injury, you've got that overhydrated skin, and then minor trauma, sometimes just separation of the buttocks to inspect the skin, causes a crack. Has that ever happened to you? You're doing separation, then you're like, oh my God, I didn't do that. I'm sure it was there when I got here. But it just shows you how vulnerable the skin is when it's overhydrated. You can also get what we call kissing lesions, so that you have 2 skin folds rubbing, This can be the buttocks, or it can be the pannus and the underlying skin. And so you'll get a lesion here and here from those frictional forces. What are we going to do? So we've talked about characteristics. Where is it? If it's ITD, it is always either at the base of a body fold or on opposing aspects of a body fold, okay? It always starts with trapped moisture. It's always either going to be a linear crack at the base or those kissing lesions. And when you look at the surrounding skin, it's usually macerated. What do you do about it? Well, you want to wick moisture out of the area, and you want to keep the skin folds separated so that they're not rubbing against each other. So they now have commercial products that will wick moisture away from body folds. But if you don't have that, you can use very simple things. So nurses have been doing this for years. We've put towels in pillowcases to separate body folds. We've used ABDs. We've used peri pads. And home care people use athletic socks under a pannus, you know, or a little mini pad between the buttocks, something to separate and to absorb. If I have to manage it, if I already have that break in the skin, then if I have access to thin, conformable dressings that will fit down into the crease and that will absorb moisture and prevent that friction, that's ideal. But what if I don't have that? What I have is my ointments. Then I can put down a zinc oxide preparation either over that linear crack or over the kissing lesions, but I'm not done yet. Because if I allow those lesions to continue to rub against each other, I'm going to perpetuate the cycle of injury. So after I put down my zinc oxide, then I should take very soft gauze or one of those disposable washcloths and tuck it between the buttocks or in the groin fold or underneath the pannus so that I stop the friction. So you can use your ointment, but it's not enough by itself. I'm going to skip pressure ulcers because that's really not your focus. So in summary, if you look at the keys to success in prevention and management of IAD, it's not that there's a whole lot of new information out there. It's not that the evidence base has changed. It's selling the program. It's making it work in the real world. So look at your products. Make sure you have what you need and get rid of any that are unnecessary. So streamline your inventory. Keep your protocols simple, simple, simple. This is what we do for prevention. If you can make it one step, that is perfect. Because what studies have shown is everybody gets cleaned up. So if you can incorporate moisturizing and application of a moisture barrier into the cleansing process, then everybody gets it. Make your protocols as simple as possible. Do your ongoing staff education and consciousness raising. I think that's what y'all did such a beautiful job of doing, is that consciousness raising. This is preventable. It's painful. It sets the patient up for other very serious problems. None of those things are anything we want to have happen, and we can prevent it. But we have to change the way we do business. We have to change our mindset. So we have to go from using those super soakers and leaving them there, layering our super soakers. No, that's not the goal. What's going to help the skin? And maybe in the States we have skin and wound champions on all these different units. Maybe it's time to introduce bowel and bladder champions who get the basics of continence management both on the urinary side and the fecal side, strategies to promote normal bladder function and bowel function, and to protect the skin. Thank you. Do I have any time for questions? Yes. Okay, so she asked me to comment more on impregnated wipes. So our data to date suggests that there's not any significant difference that's been proven in, say, one impregnated wipe and another impregnated wipe. Maybe we'll find out there is down the road, but at this point we don't have data to that effect. So what they pretty much all have in common is that they have surfactants that are designed to lift stool and urine so that you don't have to use force to clean the patient up, that they are pH balanced, so they help to promote skin health, that they employ a very soft cloth that's not going to add any kind of mechanical trauma, that they're impregnated with a product such as dimethicone or sometimes a similar product that donates oils to the skin, so helps to replace lost skin oils, and also provides baseline moisture barrier protection. So your impregnated wipes are designed to provide cleansing, moisturization, and moisture barrier. And in a study done some years back, it was a nicely done study. I think it was in long-term care, though I don't remember for sure, but they measured utilization of their cleanser, their moisturizer, and their moisture barrier because they had a 3-step program, and everybody had been taught this program. First, you clean them up, then you apply your moisturizer, then you apply the moisture barrier. And theoretically, everyone was doing this, but they monitored the rate at which the cleanser had to be replaced, the rate at which the moisturizer had to be replaced, and the rate at which the moisture barrier had to be replaced. And what do you think? The cleanser had to be replaced. The moisturizer and moisture barrier was amazing. They could just go forever, apparently. And they also tracked incidence of IAD. And then they brought in impregnated wipes. This was a study when impregnated wipes were new to the scene. And they took away all the other stuff, and then they tracked the incidence of IAD, and it dropped significantly because now care was standardized by controlling products. You talked a lot about supply line. So control the supply line, and you can control care, and you can control outcomes. Thank you.